Well, I'm pleased to bring you another video interview from Dr. Michael Cohen, who shares more of his insights into promotion of health and treatment of disease, new ideas in medicine that can benefit us all, often at lower cost than might be expected. Over to the interview now. Do check out Dr. Cohen's own YouTube channel, The Accidental Doctor, for more content of this nature. Hey, warm welcome to this talk. And Dr. Michael Cohen has come back. Dr. Cohen, thank you so much for returning.
Oh, I love seeing you.
Today's topic is really interesting, important, metabolism and cancer. But just before we start, it's just a pity there's only one of you, because we get so many letters and emails and comments saying, I wish Dr. Cohen could be my GP, but unfortunately you're the only one. So, but we've got you on video, which is the next best thing. So it's fantastic. Now, I am... Dr. Cohen and myself have not prepared this deliberately. Well, he's prepared it. He's got a lifetime's experience. But I know it's about metabolism and cancer, but I don't know the details. So I'll kind of learn with you as we go along. Okay. And this is not pretend. I am genuinely learning this. So although I've been working with cancer patients, obviously since my youth, I don't actually know much about this new thinking of metabolism and cancer. So really looking forward to this. Should we start with maybe a bit of prevention, Michael? I mean, everyone wants to prevent cancer. Everyone's been touched by cancer. Everyone's keen to avoid cancer. In terms of metabolic health and cancer, what are the links, and how can I reduce my risks, maybe at different times of life?
I'm not going to go into different times of life at the moment, but let's just say if I was to try to reduce my risks of cancer, there's a number of things which might seem obvious, but there's actually a large evidence base for. One of the most important things, apart from we can sort of divide it up, but you've got things like insulin resistance. So making sure that that your body is functioning in the best way from glucose metabolism point of view. And that means basically a number of things, but it means staying active. It means keeping your muscles active. Muscles are a very, very important metabolic organ in the body. So it's not enough to just say, go for a walk. Walking is great, but people should be actually engaging in physical resistance training. So actually building muscle. And I'm not talking about becoming Arnold Schwarzenegger. I'm talking about keeping your muscles active by doing press-ups, push-ups, pull-ups, squats. And you don't have to necessarily go to the gym to do this, but just keeping your muscles well-toned, let's say. So that's really important, and that is very important for insulin resistance. In addition, the kind of food that we eat. So you don't want to you want to be avoiding ultra-processed foods and high carbohydrate food that's very refined. You want to be having as much as possible natural foods, or sort of foods in their natural state, and that you cook or prepare at home, rather than eating processed foods that often have a number of other preservatives, chemicals, whatnot, aside from the fact that there can be, let's say, environmental toxins within a lot of things that we eat, or the way they're produced and the way they're preserved. There are actual just benefits in keeping the food as clean as possible. And that doesn't mean avoiding all carbohydrates. It means eating healthy carbohydrates that are released into our body in a good way, that they're digested slowly. Whole
grains.
So whole grains also fine. There's a whole thing about grains being unhealthy. There are some people who that's a problem for, but I think it's really more about, like everything in life, it's about having the right quantity and quality of something. So not exaggerating. The other thing that's incredibly important in terms of nutrition is fiber. Now, fiber is very important because it causes the slowing down of digestion. So it actually allows our gut to process food in a healthier way, and it avoids as much as possible glucose going too high too quickly. and then crashing down. We know that in itself is a pro-inflammatory state, so you want to try and avoid that. So by having good fibre in the diet, and you want to have things like resistant starch, you want to be having things, it's good to even add a little bit of like psyllium husk, or if that's the kind of thing you like. But the point being that you want your food to be digested slowly, and that there are certain fibers that actually improve the gut microbiome activity as well. That's without me going into too many details at the moment. So that's we've touched on sugar, we've touched on fiber. You want to avoid things like processed meats. You want to have, if you're going to have meat, you should be having meat. It's fine, but it shouldn't be all the time every day. It should be maybe a couple of times a week, and you don't want to be having processed meats. You want to have actually sort of fresh meat, as it were, cooked. This is some of the side of prevention. There are other aspects to it, like everything, and you can generalize a lot of things that can actually improve our resilience and health in a number of ways. So obviously good sleep, regular exercise, and I'll even go as far as saying good relationships, because that's actually also very important for our immune system, which is important in the development of cancers in the first place. So I think that's, without going into too much detail, that's the side of prevention. Now, if you'll allow me, I'll tell you about a couple of cases which are really interesting, one of whom I saw, this was a few years ago, and I'm going to obviously obscure any identifying details, but this was a gentleman, let's say in his late 50s, who came because he'd had a health screen, and they found that his PSA, his prostate-specific antigen, which is a potential marker for cancer in the prostate gland, was actually high on a routine checkup. And he came from abroad, and he was working locally when I first saw him, and he'd come with this result, and I confirmed the result. It was high, and did some further tests and found out that he actually did have a cancer of the prostate. And he actually had, on one side he had a couple of tumours, on the other side he had a few tumours. So the prostate gland has got two lobes, it's got a split down the middle, and he actually had quite a few different tumours, let's say, in the prostate, and it was confined to the prostate. It was considered a moderate risk. So it was not a highly invasive cancer, but it was potentially invasive, and it'd been caught at a reasonable stage when it still seemed to be confined to the prostate gland. So he'd had a PET scan, it was checked, there wasn't any other sign of this elsewhere in the body. And I sent him to a specialist, a urologist, who they did a specific type of MRI. It's called a fusion MRI, and they took a biopsy, and they decided at the time, in conjunction with him, in collaboration with him, to only treat the two tumours on one side of the prostate. Okay. And for the others, because they seemed a bit smaller, they said let's leave it for now. And the way they treated them was with a local treatment called cryotherapy. Now, cryotherapy means putting in a needle into the actual into the tumours under an MRI guidance, and then actually freezing the tumours. So he had this done, and before he even had this done, after I got the initial result, I said to him, I said, look, there's a few other things with you that we really need to address here. He was overweight. He was not living, let's say, the healthiest lifestyle. He wasn't eating the healthiest food. He wasn't doing exercise. He had a very busy job. And I said to him, I said, whatever comes out of the side of the cancer diagnosis and the treatment, these are things that you need to optimize to improve your general health and to improve your chances of getting through this cancer in the best possible way, including the treatment. And so we put him on a specific, again, it was very good. You have to work with someone who's going to work with you. Not everyone will do this, but he started doing exercise. He started sleeping better. He started losing weight. He adjusted his diet completely. I told him to take a particular supplement that's actually got a large base of evidence for prostate cancer in particular, which is called lycopene, and it's you find that in tomatoes. So he started doing all of those things, and he actually lost a good 7 or 8 kilos. He became a lot fitter. He felt better. His glucose came down. His insulin also came down with it. So these are all the things that I was talking about before. Now, the really interesting thing about this chap was that after we did all this, he had the cryoablation, so putting the needles in and freezing the tumors. What was the next step was a few months later was to repeat the MRI to see what the situation was with everything. Now, his PSA, the marker of the cancer, had come down dramatically. What was really amazing was that when we did the MRI, the tumors, the two tumors that were treated on one side of the prostate, they were gone. Now, that was a good result, but it was also an expected result. What was completely unexpected was that on the other side, all the other tumors had disappeared completely.
There was no question about the initial diagnosis. There were definitely targetable lesions.
This was a definite prostate cancer. And there's actually a name to this effect, and it's called the abscopal effect. And I believe it was discovered by a British scientist in the 1950s. Now, there's about, as far as I know from the literature, less than 50 cases worldwide documented of such a thing happening. Now, what's the relevance to what we're talking about here? I can't say for sure that I'll tell you about what's called the abscopal effect in a moment, but the question is also, what did the metabolic changes that we put this chap through, did they have a contribution to this? So the abscopal effect is something incredibly rare. But it is documented going back at least sort of 70, 80 years, whereby you treat a tumor in one place and without treating it elsewhere, so you didn't have any chemotherapy, radiotherapy or whatnot, the other tumors disappeared. So the theory behind it is that basically by treating the tumor in one place, you're exposing the tumor antigens, the parts that the immune system can see, and it becomes like a danger signal. It's kind of like, okay, now I've been exposed, you can recognize me, this is the kind of cancer that I am. And in some people, in certain situations, the immune system takes that almost like a vaccine and then starts attacking other parts of the tumor elsewhere. And that's probably, that is what seems to have happened with him. Then the other question comes out, in view of the fact that this is something so rare, this particular
abscopal effect.
The abscopal effect, was the metabolic part of the treatment also something that increased the chances of that happening? Now, I don't know. I'm not going to sit here and pretend that I do, and it's very, very difficult to prove it. But I do think that it's very likely that in him specifically, with all the other things that were done, they created, let's say, the optimal milieu, the optimum environment conditions, surrounding conditions for this particular thing to happen. And so he was, as I said, treated on one side and the other side disappeared. That's one case. And I'll tell you about another case now. This is not someone who I know personally, but I've seen a lot of patients over the years whom specific types of metabolic optimization actually resulted in an improvement in their cancer. I'll tell you a couple of things. One, there's, if anyone on your channel wants to read, there's a doctor who now passed away, unfortunately, but he had a brain tumor. I think it was a glioblastoma. I'm not sure. And he was told basically you've got something like a year to live. His name was David Servan-Schreiber. He wrote a book called Anticancer, which I would recommend anyone to read. And he basically didn't want to accept this, and he himself was a medical doctor, and he decided to do everything possible within reason to treat the cancer beyond what was the cancer itself. So in other words, he optimized his own metabolic health. Now, how did he do it? He basically did it mainly with food. He did it with sleep. He did it with exercise. He did it with meditation, positive relationships, and things like this. And he survived 20 years.
Wow.
So in someone who was told that you've got a year, maybe 2 years to live, it's a really remarkable story.
I mean, we've seen patients with glioblastoma die in months, or certainly a year or so.
And usually a year, 2 years, maybe 3 years, or something, you know. And I think it was a glioblastoma, but the point was that the prognostication for him was that it was going to be, very, very short, and he wasn't going to survive long. And now I'm going to tell you another story. It's not a story. This one is more of a case. This was in one of the southern states in America. It's these things have been interesting me for years, and I've spoken to other doctors who've experienced these kind of results, let's say. A patient, now pancreatic cancer, for example. Pancreatic cancer is known to be absolutely horrific. Most people with it will, if without treatment, will die within months.
Yeah.
And even with treatment, something like 95% of people who receive treatment will actually die quicker with the treatment than if they just leave the cancer alone. And the reason being that it's such a high risk, aggressive problem that their chances are so small that people are willing to take the risk, and they take the risk. They get treated with chemotherapy, and about 5% of them will have a good result, meaning they might last a few more years. But 95% of people will actually die sooner than had you left the cancer alone. Maybe not by much, but it won't exactly help. It will harm. So this is an example of where we say first do no harm, but when you're doing it in the context of trying to give someone a chance of actually living longer, if someone is willing to take that risk, then that's the usual outcome. So there's a doctor in the United States who had a few cases of people, not just with pancreatic cancer, also with liver tumors and lymphomas, I believe. And he treated them with something that I've spoken about with you in the past. I think alpha-lipoic acid, low-dose naltrexone, and vitamin C, depending on the type of tumor. And there's very sound biological reasoning to this. So tumors cancerous tumors usually have they go to a more anaerobic type of metabolism. So a metabolism that doesn't that needs less oxygen. And what taking our alpha-lipoic acid does is it pushes their metabolism towards a more what's called oxidative phosphorylation. So it moves them away from anaerobic and more towards aerobic metabolism. And then taking something like LDN, low-dose naltrexone, that causes the body to produce its own internal opioids, so basically heroin inside your own body, or morphine, whichever way you want to look at it, and that has certain effects on the tumor environment, and it can actually then cause apoptosis, so it can cause cell death to those tumors. So he has, for example, a case that I read about where, and I've spoken with him in person more than once, where he had a patient with pancreatic cancer who was alive and well, something like, I'll tell you, about 6.5 years after the treatment, after the diagnosis. And this person did not receive any chemotherapy or radiotherapy or surgery. And he did it basically using these things. Now, these are using metabolic medicine to treat a cancer. Now, the usual reason, the whole way in which medicine oncology has thought of cancer has been through the somatic mutation. So you've got a cell, something goes wrong in its DNA replication, a mutation happens, and for various reasons that proceeds until you've got a tumor, and then it metastasizes. It can go off to different parts of the body, etc. Now that is a very real thing, and it's proven by multiple studies over many years now, and that's been the main thesis, let's say, for how to approach cancer. But that's looking at the actual tumor. The problem with that is that there's probably more to the story, and there is more to the story, but it depends on each tumor and what the actual environment that the tumor is in. So we know that some cancers are more sensitive to metabolic changes than others. So we're talking now about, we've passed prevention, we're in the realms of treatment, obviously. Breast cancer, colorectal cancer, that's the large colon and the rectum, pancreatic cancer, and I think also prostate cancer. These cancers are known to be more sensitive to metabolic manipulations, let's say. So there are things that you can do that can actually push these cancers into a more dormant state. Now that could mean in some cases actually completely regressing the cancer, but more likely it could mean just making the cancer more indolent, so it's not as aggressive, It might be more amenable to treatment. It might, that you have other options to you. And I think that the focus in medicine is obviously correct that you need to attack the tumor, but there are other things that we don't really look at because these things, it's not easy to, first of all, it's a paradigm shift in the way we think about cancers. And on the other hand, it's also something that it's very hard to get the economics of a trial going. Okay, so when you've got things that are very, very cheap, the only way to, I guess, to bring them into a trial is to start adding them into something else that you're already doing, which makes the trial a little bit less pure. Yep. But I think that may be the way forward, that we can actually start bringing in other metabolic changes at the same time as using the regular treatments, let's say. And I think that there is some movement in that direction now in medicine. There are other types of cancers, such as acute myeloid leukemia, and I think lymphomas as well, which are cancers of the blood system, of the bone marrow, of the production of blood cells. And there is some evidence in some cases that, for example, high dose vitamin C, given usually intravenously, can actually, vitamin C works slightly differently. It causes the body to become more pro-oxidant, meaning that it's causing the production of more reactive oxygen species, which in turn results in the other cells in the immune system basically responding and attacking that cancer in specific cases. And these are the range of subjects that we're talking about, and there's more as well. I can't go into every detail, obviously. The point being that you have to look at cancer not just in isolation as, one might think, I've got cancer, there's a cancerous tumor inside me. You have to start thinking, hold on a second, what else can I do in addition to whatever else may or may not be right, or whether I want to do other treatments that can actually optimize the chances of this tumor regressing or being in a better state for treatment. I think I'll let you talk a little bit now.
No, that's fantastic, Michael. I think this is part of the problem. People know about all these, well, not alternative, but additional treatments really to treating cancer, but they're not quite sure which is which. I mean, it strikes me there that breast, colon, pancreas and prostatic are all glandular type tumours, all adenomas. So maybe that's a classification, whereas the acute myeloid leukemia and the lymphoma are more sort of bone marrow related.
Yeah.
And most doctors simply don't know the optimised strategy in terms of these additional treatments, which can be transformative for particular cancers. We really need this to be documented, and even though it's not for sure, it'd be really nice, wouldn't it, to have some sort of algorithm that suggests particular alternative treatments for particular cancer types.
Yeah, I think, it's possible to develop a safe algorithm anyway, because you're talking about low-risk treatments in general. I think it needs to be realistic in terms of what the expectations are. There's a researcher called Dr. or Professor Thomas Seyfried in Boston University in America. And for at least 20 years now, he's been doing really remarkable work on the mechanisms. And they have done trials with glioblastoma, actually, brain tumor. But I don't think you can generalize it to all cancers. The problem is that tumors are not necessarily made of one cell type that is more oxidative phosphorylation or anaerobic. So the problem is that you can't just say, okay, I'm going to do this treatment, this metabolic treatment, and you may have some anecdotes where some people do really, really well, but there'll be others that they won't do so well, and that's simply because you've got different types of metabolism happening within the same tumor. And there may be some tumors that are more prone to having one type of metabolism, but then when the tumor starts metastasizing, when it starts coming, let's say, out of its original position and moving to other parts of the body, the metastases themselves can also have different types of metabolism. Dr. Seyfried talks very much about ketogenic therapy. So by reducing, so here we were talking before about insulin resistance and glucose, and eating the right types of diet for prevention. So in terms of treatment, ketosis, which is when a person basically almost completely or completely stops eating sugar, glucose, carbohydrates, and they literally run their body on protein and fats, then the body goes into a different type of metabolism, which is ketosis. So you start producing ketone bodies, and ketone bodies can also be very advantageous in dealing with many types of cancers, because the cancer is being basically starved of glucose, if you want to look at it that way. It's not getting glucose, and it doesn't necessarily run so well on ketones. But again, it's a nuanced subject. There are tumors that will run with the ketones. It's not a straightforward thing. And there are other cancers that also run on glutamine, and glutamine. So Dr. Seyfried has basically said, well, we can start using a drug called which blocks glutamine, and that theory can also that can work in practice, but there can be significant side effects of those treatments as well. So I guess what I'm trying to say is that it's a nuanced subject, but what I would like to I think that a very, very important message of all of this is that people need to understand that they're not passive in all of this. It's not just, I've got a diagnosis of cancer and there's nothing I can do. There are, first of all, there are definitely plenty of things you can do to prevent yourself getting cancer. Something like 1 in 3 people will get cancer at some stage in their life, if not more than that. And many of those cancers, by the way, for example, prostate cancer, if you live long enough, all men will have prostate cancer.
Inevitable, yeah.
They just don't know that they've got it because they've got no symptoms, and it never causes any problems because it just happens when they're 95 years old or something, or 80 years old. But they just, they may even have a tumor, and we won't treat it. We'll just keep an eye on it and see what's going on with it. The point being that we all have a propensity towards cancer to different degrees, and we may all have tumors that are growing within us, and then our body's immune system deals with all the time. So the empowering part of this is, how do we get people to improve, to optimize their own, let's call it the soil in the garden.
Yes.
So that they can actually combat cancers in their early stages or at later stages if they actually develop into tumors. And but there are things that can be done that are that are not too medical, let's say. They don't involve expensive drugs, they don't involve expensive treatments or with high risks. But it is something that it's a developing field. And I really think that it's obviously a very important part of the future for cancer prevention and treatment.
I mean, it seems with traditional treatments like chemotherapy and cytotoxic agents, we're prepared to accept absolutely appalling levels of side effects. The idea that things are safe. I mean, cytotoxics certainly aren't safe. I mean, obviously you've got to do what your consultant prescribes, but I mean, people die on chemotherapeutic agents without being too alarmist about it, and the side effects are totally appalling. And yet, when we talk about these alternative things like low-dose naltrexone and vitamin C, they're remarkably safe treatments.
Yeah.
And yet, in the medical establishment, there seems to be this great resistance to it. It's people kind of say, well, where's the randomized double-blind controlled trials on that? Well, the randomized double-blind controlled trials on these often highly toxic treatments are done by very expensive clinical trials run by very swish pharmaceutical companies who are starting to make a lot of money. And the other thing the pharmaceutical industry does, they tend to get a treatment that's fit for one cancer. So, there's probably a couple hundred, I don't know what the official figure is, a couple of hundred different types of cancer. So you want a treatment for cancer A, a treatment for cancer B, a treatment for cancer C, a treatment for cancer D. Whereas these things basically, we think of things like Professor Dalgleish, who's basically developed a bacterial inoculation that upgrades the entire T cell response.
Professor Dalgleish actually, I followed him for a while. I think I was in touch with him a long time ago as well. Also has used low-dose naltrexone.
Very much so. He's written several papers on it. And low-dose naltrexone, even with conventional chemotherapy, can actually half the required dose. Mm-hmm. And if you half the required dose, you get rid of nearly all the side effects.
So this is exactly the point. Even vitamin C, I've got a patient at the moment with melanoma that has spread into the bones in one of their arms. and is receiving a biological, I think is receiving an immunotherapy. So receiving a standard, though very advanced treatment for it. And in discussion with her oncology team, I've been giving her intravenous vitamin C.
Wow.
And it doesn't make everything better, but it's made her much more resilient to the treatment. She's much more able to cope with the treatment, not having fatigue, able to cope, not having side effects so much of the treatment. So it's not an all or nothing thing. It's not that at the moment we know that if you just get vitamin C, everything's going to be wonderful. Not at all, but it's very much about starting to think a little bit more rather than just saying, okay, this is what it is. In response to what you said about different all these different agents, whether it be chemotherapy, now there's biological therapies, there's CAR T, there's all sorts of stuff that's going to be happening more and more in the future. But in response to what you're saying, I think first of all, as a paradigm shift, right? Medicine. It's just a little bit shocking when you've come through medical school, and it's very hard to go through medical school for years, and you learn certain things, and these become the foundational understanding of any particular branch within medicine. And then someone comes along and says, well, actually, vitamin C could work, and it almost sounds ridiculous. Okay, even to doctors, maybe especially to doctors, because there is a certain cognitive bias that you develop, because you think, no, that can't be right. It's just like, no, it can't be right. And nobody's looking at the very, very basic biology. And I can give you loads of examples of this, and not just on the side of cancer. And we'll talk about it in future exchanges. I think that's the first step, and then there's the other barriers to doing this, which is how do you arrange for these trials to take place, and even convincing patients. I can tell you, I've got patients who I've tried to say to them, listen, you should be thinking about this and that, not necessarily related to cancer. And even though they know that, we've got a long-term working relationship together, they trust me and everything, and they can be resistant to trying things that nobody really knows for sure, even though they're very, very safe options. Something like low-dose naltrexone, vitamin C, whatever it be, alpha-lipoic acid. So the system's not entirely there yet. But I do think that with time these things will become more and more prominent.
And I think things that aren't going to do any harm. It's all about risk-benefit analysis to me. If something's not going to do any harm, then why the heck not try it?
For sure. And I think, but even on the subject of harm, to give the other side of the equation, there will be those who say, well, we actually don't know if this is safe. We actually, because it could be, there are certain cases where they think, for example, vitamin C could push a tumour to becoming more aggressive. So the question, and so they're only now starting to understand the mechanisms by which these additional therapies can actually help or potentially harm. And there are specific mutations, for example, in colon cancer, whereby they know that if you've got this specific mutation, vitamin C will actually likely help. But this is
help the condition or help the cancer.
Help the condition.
Yeah. Be therapeutic. Yes. Yeah. Fascinating. I mean, I don't think our pharmacy even stocks intravenous vitamin C. We have like a combination of vitamin C and vitamin B that we give to alcoholics and people with vernix and things like that.
Right. Usually it's made up in compound pharmacy. So I use a pharmacy where I am in contact with them. I say, listen, I need you to make up
IV vitamin C,
or IV vitamin C, or there are other IVs that you can put together.
And it probably kills virus. It's probably one of the best treatmants for sepsis that's not used as well.
Well,
it probably kills most viruses.
It has,
and most bacterium.
It definitely has antibacterial, antiviral properties. There was a trial done in an intensive care unit a few years back, maybe about 5 years ago, but they didn't, at the end of the day, find a great benefit. And if I think that. But I'm not sure about the details.
That is correct. Pierre Corey actually covers that in his book on the war on ivermectin. And Pierre Corey and what's that brilliant South African doctor called who works in the States. His name escapes me, but they wrote a paper and they got very, according to Pierre's book, they got very positive results. But the shall we say, the results that appeared in the paper weren't exactly the same as the results they got by the bedside.
Very possible. Very possible.
But well, you might expect that because vitamin C is cheap.
It is cheap, and what are you going to do? It can potentially help a lot of people. I think. I think that the research will more and more emerge, though, because I think that people are more and more open to thinking in this way.
And for treating sepsis, sepsis still has a very high. Well, all infections, of course, as antibiotics become, probably more problematic.
No, we're definitely going to be looking for certain. We're going to be looking for the other things that.
If you could get an infection and the GP could give you an injection of intravenous vitamin C and it goes away, that would be desirable if that's the case. And
for sure,
at the moment, I simply don't know. Curious, how much do you give? Do you remember?
For what? For intravenous vitamin C?
Yeah.
Well, it's a bit of it's a nuanced subject. First of all, you need to make sure that the person doesn't have something called G6PD deficiency.
Yes.
If they do, then you have to be very careful with giving vitamin C. It's not that it's that common, but there are certain populations which have it. And so
it's often Mediterranean associated, isn't it?
It is, yes.
Glucose 6-phosphate.
You just need to be careful about that.
Yeah.
Assuming that they don't have that deficiency, then you may start them on a dose of something like 20 grams, which sounds like a lot, but when you're giving it as an intravenous infusion, it's not that much. And you can go as high as sort of 70, 75 grams.
Wow. Really?
Yeah. Right. And even 2 or 3 times a week. Again, it's done carefully.
Do you run it in as an infusion over an hour or something?
You run it in as an infusion, yes, usually over about an hour. It can be done quicker, it can be done a bit slower. And it's very important that people eat something during that time. It has a tendency to drop their sugar levels a bit.
Okay.
Let me tell you another little story. It's an amazing story and also a bit of a tragic story. And I won't go into too many of the details because they, this video will get flagged as something else. But I can tell you about a patient who I saw when I actually went to visit a clinic in South Africa about 5 years ago. Yep. And I was sitting with the doctor, and he was there was a patient. She was in her 60s. She had metastatic breast cancer, so breast cancer that had spread into her bones, into her liver, and even into her gut, which is really, really rare. But the point about the gut was that because of that, she was actually barely able to eat. And she'd had everything. She'd had her mastectomy. She'd had both breasts removed through surgery. She'd had radiotherapy. She'd had chemotherapy. And they just weren't getting on top of this tumor. And eventually they came to, and she couldn't eat. So they left a line in her chest here, which was basically a port that goes into her central veins. So they could easily give her intravenous fluids or medications or whatever. And at that point they said to her, look, this is not working and there's nothing else we can do for you. And we're just going to give you painkillers, morphine. And you need to go and get your affairs in order, and say goodbye to your family. And she went to see this doctor who was actually a GP, and he gave her intravenous vitamin C and something else that I'm not going to go into, nothing dangerous, but he gave her intravenous vitamin C 3 times a week, and it's not just vitamin C, so it's very important I emphasize that. Otherwise people will start thinking that they can do this. And the remarkable...
You're not going to give us a clue to the other one at all.
I shouldn't, because it will be flagged. It will be, and it's in my opinion, it's not something dangerous, but it needs to be done carefully and properly. And most people don't do these kinds of things. Got it. It's not arsenic poisoning or anything like that. And this woman's cancer started regressing. And she was able to eat again, and she was in less pain, and there was a significant regression of her cancer, and she didn't survive. She lived, I think, at least a year and a half maybe 2 years. Wow. But she was supposed to, according to the rate that she was deteriorating, she couldn't eat. She was.
You're talking days.
Not days, but definitely weeks, maybe 2 months, 3 months or something like this. And she went on for another year and a half or so. And the sad thing is, you wonder what would have happened had this been instituted much earlier.
Oh, yeah, I know.
With or without the other treatments. And so this, again, it's a case of, I can tell you, I've got long lists of patients that I'm aware of, people who I've seen, people who I've spoken to, other doctors around the world, where a little bit of thinking outside of the usual has made a significant difference to their cancer survival.
Yeah. It's interesting you're talking there about low dose naltrexone increasing morphine metabolism. There's this old saying in healthcare that sometimes when we start patients on terminal morphine, they thrive on it. And they just seem to, I've always kind of assumed it was because we've got rid of the pain, so they go back, start cooking again and start doing the shopping again and going to the grandkids again.
I'm sure it's more than that, you're right.
Yeah, there could actually be some therapeutic effect of
there could be. I mean, with low dose naltrexone, the mechanism is slightly different because you're purposefully giving them. Yes, obviously, no. I get what you're saying. I'll stop it there. I think there is something to what you're saying, because low dose naltrexone just basically causes your body to produce morphine of its own.
Right. Yeah. Yes, and that's what it was used. It was originally used for heroin addiction, of course. That's
correct.
What it was originally used for.
And then it was then somebody very smart in the 1980s, when the AIDS epidemic started in New York. A doctor called Bernard Bahari started playing with it because he'd already used it in very low doses for other conditions, and he started playing with it. And when they only had one drug at the time for AIDS, and that was AZT. Yeah. And he started adding it into people's therapy and gave them tiny doses of naltrexone. Yeah. And at the time, I don't know how long this follow-up went on, but these people many of them were surviving much, much longer than anyone expected, because they didn't have any real treatment. And that's how it started. And since then it's developed, and
And again, low-dose naltrexone basically isn't available from British pharmacies. It's preposterous. Professor Dalgleish has got a particular pharmacist up in Edinburgh or Glasgow, I think.
I remember it was in Scotland.
It was Edinburgh or Glasgow. And, he has to have it made up specially by this particular pharmacist and then shipped to his patients. It's just... for something that's so safe. And apart from if it's safe, why not try it? You've got the whole right to try thing. If someone's got a terminal condition and they want to try, I don't know, Artemisius annua or something, from Italy, then I'm actually growing some here. This is. This plant won the Nobel Prize in 2015. For treating malaria, So.
Yes.
Why shouldn't they be allowed to try it, or other repurposed drugs that, as you say, could be mentioned? I'm reminded of the story of Daniel, who refused to eat the king's food and ate simple foods, and at the end of the trial period were more healthy looking than all the other young men who'd eaten the king's rich foods and the king's wine. Of course, we don't want to drink too much of that stuff either. Big question left in my mind, Michael. Vitamin D as a preventative and a treatment.
So I wouldn't. Let's put it this way. I wouldn't put lots and lots of weight on telling people, hey, if you do this, you're not going to get cancer or something like that, or it's going to dramatically reduce. But I think that there is some significant body of evidence that having good levels of vitamin D always throughout your life is important. And it definitely seems to improve cancer rates in certain cancers. I can't remember the literature right now, so I'm not going to sit here. No. I've definitely read about it, and has improved survivability as well.
In prostate cancer is an obvious example.
And that's one of the things that I gave this chap as well, was to get his levels up to a much higher level than they were.
And again, things that are good for prostate cancer, given that it's a glandular type thing, again, you think breast, colon, pancreas, all glandular type, type tumours, what we call potential adenomas. I think it kind of makes sense.
Well, as you say, it's very much about benefit versus, risk versus benefit. And I think these are low risk strategies with potential benefits. the question is really about identifying who's going to benefit.
This is the key thing. We need to know which particular additional low-risk treatments for what particular cancer. This is the frustration.
Yeah, that will be helpful. And that
at the moment,
I think, will emerge in time more and more.
I think the anecdotal experience from practitioners such as yourself is absolutely vital.
It's vital in finding directions. It's vital in finding directions.
Yeah, no, this can be collated into cohorts. The idea that we need to do an expensive, randomised, double-blind controlled trial for all our interventions is playing right up to the big pharma's backyard.
I think without being conspiratorial, let's say, I think there are certain economic motivations for things and laziness, right? There's a certain laziness of thinking, and it happens with all of us. And
inertia.
And inertia, right? You've got to change something you're doing. It's like, what's going to make me change my practice, right? It's like, I'm so busy, I've got so many things to read, and now you're going to tell me that there's this other thing that I can do, and you haven't got any real proof for it. You can see how a mindset develops, which is not conducive to what true science should be. Now, what is true science? Like, from my point of view, I came into medicine very haphazardly. I came in literally, I didn't even know that I wanted to be a doctor. I didn't want to be a doctor. I had no inkling to be a doctor in my life. And a friend of mine in when I was 16 said to me, why don't you come to, I said, what do you want to do? And I said, I don't know. And he said, come to medical school, as though it was like going for a walk in the park. and I said to him, what if I don't like it? And he said, well, you can leave. I said, well, what do I do then? And he said, well, pretty much anything. It's a very good first degree to have. And I was, totally, I just believed in enjoying whatever I did, no matter what I do. I said, I want to enjoy whatever I do. And I actually loved medical school, but even when I finished medical school, I was like, I'm not going to be a doctor. I've just done this now. I don't know what else I'm going to do. And I kept trying to leave for years. And the reason I'm telling you this is simply to say that, even going through medical school and everything, you learn all these things and they become your norm. And you think, well, this is the way things are done, and this is it. But true science is something that we all have in us, which is a basic human curiosity to experiment. Now, I experiment on myself. I experiment on my patients all the time, and I don't call it an experiment, but I tell them very clearly that we're trying this as opposed to this, and this is the benefits and risks, or we're trying this in addition to this.
It's only because you've got a pretty good idea it's going to be efficacious. I mean, it's not a random experiment. It's not
a random experiment. Obviously, it comes with responsibility and explanation and a collaborative approach.
Concordance. You come to agreements with your patients.
For sure, and follow-up, which is hugely important, right? And we're not talking about treating a heart attack with eating oranges. We're talking about, we're talking about things that are reasonable, things that are preventative. They're less sexy, right? They're not the same as, I used to work in emergency for years and surgery, did all sorts of very, very exciting things. But the actual numbers of patients that you can, whose lives you can improve through prevention and ongoing education, I guess, is vastly more than the few that end up on the operating table by comparison. But the only thing I wanted to mention that was exactly this to develop a passion for experimenting in the positive sense, and how I think that's where medicine needs to go back to. It's much more. Yes, there's a lot of anecdotes, but there's so much more that can be learned. Because you're learning about yourself, right? You do something and you see the results, as opposed to, well, here's a randomized control study and we're treating X amount of patients and we know that 30% of them do well. Well, great, that's fine for the 30%, and we don't know who those 30% are going to be. What about everybody else?
Absolutely. And if I came to you with a condition that was difficult to treat or didn't have a standard treatment, and you said, look, John, my intuition tells me this is going to help you to some degree, then that's worth a lot, because as we go through life and we see lots and lots of patients and teach lots and lots of students, you do develop a certain intuition really for disease. And also, it's more, what I'm saying is much more than guesswork.
Sure, but the guesswork also involves the patient themselves, right? There's
Yes.
the person. Okay, so there's the disease and then there's the person. And that's the part which needs to be matched. You can't just, it's like, I get patients all the time who, what can I do for this? Okay, you can do this, but many of them won't do it. And then the other type of person or another specific person will do it, and they'll be engaged and they'll be involved and they want to, and and it's about working with people, sparking their curiosity, sparking their motivation to actually benefit from something.
Yeah. It's basic evidence-based medicine, isn't it? It has to be acceptable to the patient. That's part of it. That's part of the original David Sackett sort of thinking with evidence-based medicine. So I just think we're so desperate now for alternatives to expensive randomized controlled trials. The example I like to use is Richard Doll and Austin Bradford Smith managed to work out that smoking causes lung cancer.
Yeah.
And that's without a trial. That was just taking, all they did actually, well, as you'll know, but the main thing they did there was survey British doctors. And the ones that smoked got lung cancer much more frequently than the ones that doesn't. And then the follow-up study, the ones that smoked got much more coronary artery disease.
Yeah.
And, that was just basically two guys thinking about it, being clever, working with results from questionnaires and putting together new ways of analysing evidence, as typified by the Bradford Hill criteria, for example.
And think that this was at a time when doctors were advertising cigarettes as a healthy habit.
I know. It's unbelievable. Well, of course, it helps to bring up the phlegm, doesn't it?
Absolutely. There was a rationale there.
Yeah.
There was a rationale.
Well, you can actually see it when you have your first cigarette in the morning. It brings the phlegm up. That's because we now know that's because the nicotine and the tobacco smoke have paralysed the cilia overnight.
Yeah.
But it's we're just so desperate for this alternative way of collecting data, and be interesting to see as well as we collect more cohort type data.
Yeah,
we've got AI to help with analysis now as well, as long as that's done under strict human supervision.
Yeah, the AIs make a lot of interesting interpretations of things. Let's say a connection.
They do, but it's also they provide food for thought, shall we say?
For sure,
which is interesting.
But I'd love also. I mean, I talk about some of the things that we talk about. I've rejuvenated my YouTube channel recently, and so I'm going to go into more depth with these subjects as well in videos that I'm doing as well. Specifically about N=1, about cancer, about other things as well.
No, I mean we would love to do that, of course, and. It's just a remarkable. There's so many bad things about modern technology, but basically we've got your knowledge and clinical experience now, and it has to be said, curiosity and free thinking, which potentially benefit now millions of people around the world. It really.
I think we all need to be of that mindset. We really, I think also, I'm not going to go in for too much, but the one of the things that causes burnout in doctors, for example, is exactly not having, the whole focus has become about conditions of work and about how I've only got 10 minutes to see a patient or whatever it be. But if you want to combat that, you need to build the doctor as well, or the person. You need to, the focus needs to be on how do you rejuvenate the thinking that this person had when they first went into medical school, the enthusiasm, the desire to learn from every patient, right? These are the things that can combat stress and burnout, and not just I'm going to change the policy in the hospital, whatever. We're losing why we went into medicine in the first place sometimes, and that's sad. That happens because you get so tired that you just think, okay, well, I just got to do this, I've got to do that, and it's a kind of coping mechanism.
Yeah.
But I think the more that we can get curiosity back into medicine, I think the more chance you have of improving care.
Indeed, and it's very good for the individual as well. I mean, I know doctors who are, shall we say, fairly well past retirement age, and they still might see patients, they still give advice, they still do some writing. Some of them condescend to come onto my videos, and it's really good for the individual to do that. I'm reminded of Alistair Cook, who was an old journalist. He wrote something called Letter from America when I was young, and he was well into his 90s. And he said, people ask me when I'm going to retire. I said, well, I'm not. I've noticed that people retire keel over shortly afterwards.
Absolutely.
So really good for the individual, really good for the patient. Dr. Cohen, thank you so much. And as soon as these other ideas are there, let's record them. And it really is wonderful that you choose to share this with the whole world's population who can benefit from it.
Well, I think, anything that, I think we should all be doing this as much as possible. There's so much out there that people can benefit from, and it's not expensive. It doesn't cost anything specifically.
Correct.
Or not much.
Correct. Yeah. And on a frivolous note to end, it makes my job really easy because you do all the hard work and the thinking, and I just sit here. In this video, I've actually been reveling in it. Amazing stuff. Made quite a few notes, things I need to look up, gaps in my knowledge, as you would expect. But
I've got gaps, got plenty of gaps. Even after I read something, I've got to read it again and again, remind myself. It's not
I'm a very gappy person, I must say. Doctor, thank you so much, and God bless, and we'll see you again.
Thank you.